This is the way we're going to do it. We are first going to review what we had in our last course. It's a 5-minute summary. Then I'll try to point out what is now new in 2030, and then we're available for open questions directly from our audience. I would like to point out that, of course, we're a bit time limited. We will try, Dr. Kramer will try to select cases which we think are very hot, but we're not trying to push off other questions. Any questions you send in, we will ultimately also answer by email. How do I end? No, can I do it here? I'd like to do it here. Okay, now in our 2012 course, which was really done in 2011, we looked at the biological factors of PSA. We looked at PSA as a marker of the risk for current and future prostate cancer, and we looked at it as a marker of BPH progression, as well as analytical and individual factors influencing PSA. I will not go through all of this. This course is still available and can be accessed on the web of the EAU Education online at any time. And what I will do is basically just look at what is new. Now, just to summarize what we had said at that point is that serum PSA has a broad clinical utility in prostatic disease. Any elevation of serum PSA is characteristic of some prostatic abnormality or disease, such as prostatic cancer or BPH. However, PSA is organ-specific, but not tumor-specific or disease-specific. The measurement of serum PSA levels has an interest in, for example, looking at prostate cancer and the likelihood of having current biopsy detectable prostate cancer, but also looking at the chances of future cancer. It is, of course, but we will not talk about this today, an excellent marker on prostate cancer treatment. In BPH, it is a very valuable factor in looking as a prognosticator of BPH progression, and it is a surrogate marker for prostate volume. Now, what was one of the probably most striking findings in the last couple of years was the finding from the PCPT trial, the prostate cancer prevention trial, which was a very, let's say, artificial trial because people had a routine biopsy regardless of PSA. And in fact, at a level where PSA was thought to never really indicate prostate cancer. All the patients had to have a PSA below 4. Now, if you look at it, you can see that if you look at the red lines, risk of any prostate cancer, there is an ongoing risk of prostate cancer, even at these low PSA levels. And this is even true for high-grade cancer. There is no clear value where you can rule out prostate cancer. It never falls to 0. This, of course, has significant implications on how we use it. The usual way up to that time was that PSA was correlated to a positive biopsy. But already the threshold for biopsying a patient in pounds sensitivity and specificity of PSA. This is reflected in this somewhat complex slide by, This is reflected by the somewhat complicated slide by the various thresholds. If we use thresholds like, for example, 2 or 4, it is quite easily visible that sensitivity, which is the proportion of patients that are truly positive, goes up the lower the threshold is. And in the other way around, if specificity, which are the true negative, is used, the threshold goes, with the higher threshold, it goes up. This basically means that if we use a low threshold, we will have more negative biopsies, and if we use a high threshold, we will have more prostate cancer is missed. The important issue is there is no PSA threshold that provides a high sensitivity and high specificity. This is something we've learned in the last years, and there is a continuum of prostate cancer risk at all values of PSA in this within this line. Can't I advance it here? Now, if we look at the current approaches, therefore, which sort of came out of this, and I'm still talking about our last course, the statements where there is no single threshold value which should prompt prostate biopsy, currently recommended by any guideline. PSA is organ-specific but not tumor-specific. The decision to proceed to prostate biopsy should be based primarily on PSA and DRE, but it should take into account other factors such as patient age, family history, prostate volume, and whether there was a previous biopsy. And this all can be incorporated in risk models, which are available, risk calculators, which can be used to calculate the individual risk based on these risk factors. Now, if we look what has changed, I've shown that here in red. There are some new approaches to PSA as a marker of risk of current prostate cancer, and we have new data on its role as a marker for future risk of prostate cancer, but also, and this is a new point, as a prognosticator of the aggressiveness of an individual cancer which has already been identified. And these are the points I'd like to cover today. Now, looking at a marker as risk for current prostate cancer. Next. In 2013, the AUA summarized, and this is a quote I take from Dr. Carter's editorial in the British Journal of Urology, a systematic literature review which really covered everything, including all other forms of diagnosing prostate cancer, such as other biomarkers in the urine and in the serum, imaging, genetics, and biopsies in the mouth. And they came to the conclusion that only PSA was a test that evaluated the a priori outcomes of interest, and that's what's to be concentrated on. It was therefore even more stunning for the urological public when just shortly after this statement, the U.S. Preventive Services Task Force, a task force which was mainly composed of epidemiologists, also reviewed evidence for PSA screening. And I'd like to point out it was basically the same evidence for prostate cancer and came to the following conclusions. There is moderate or high certainty that this service has no net benefit or that the harms outweigh the benefits. They recommend clearly against PSA-based screening for prostate cancer, and this was a grade D recommendation, which is the highest form of recommendation they can give. And this recommendation, of course, they pointed out, applies to men in the general population regardless of age, and it does not include the use of the PSA as a test for surveillance or treatment after the cancer was diagnosed. Therefore, we're not going to talk about this last paragraph. We're just going to look at the first two. This really hit urology. In fact, it was released at the time of the 2012 AUA, and this was the headline in USA Today the day the meeting was started. And if we go on, I'd like to, can I do that myself? Because it's easier for me. When this was started, these were the messages that came up. Doctors shouldn't even offer it anymore to healthy men because there's more harm and the chain of medical interventions is much more of a disadvantage than advantage. And they even pointed out, please note, all of this was on the first page of USA Today. Treatment can even be deadly. 1 in 200 men who has prostate surgery dies shortly after the procedure. Now this hit all of us, and because of this, I would like to ask a question to the audience, and if you would just answer this now. Do you agree with this? Doctors should no longer offer the PSA test to healthy men Please vote now. I agree or do not agree. Can you vote now?
Yeah.
Can I use this here? Okay. I can only use this. Okay. Okay, well, it shows that some of us agree, but the longer I wait, less of you agree, which is good because apparently I'm convincing you that this was wrong. Well, anyhow, it was information that hit urology, and as a result, we really have to look at this in more detail. Can't I just advance it? All I want to do is advance it.
But you need to go from this.
This is very... Now, these are the data which the Preventive Cancer Association used. Basically, of course, one has to stay with hard evidence. And there are, at present, 3 published prospective randomized trials where cancer mortality is the endpoint. There's one from the United States, the PSA study, which showed no difference between screened and unscreened population or controlled population. The problem with this is that the screened population is really a population which had opportunistic screening. There was a 52% contamination, and in addition there was a 30% dilution, so that in fact this study is underpowered. But it did not show any advantage of systematic screening over opportunistic screening. The bigger trial is the European trial, which covered 180,000 people, which were followed up to an 11-year, and it showed in its first analysis, or in its second analysis, a 20%, 21% reduction in prostate cancer, which was considered highly significant. There are some differences here, and this has been some criticism of these trials. This was a multinational trial involving many groups, and there were some differences in screening intervals from 2 to 4 years in the age of the patients. And one of the criticisms was that it was really 2 groups that showed this improvement, whereas other groups did not show it. But this was a highly significant proof of a positive impact on mortality in at least one could consider relaxed screening. Now, the third trial I'd like to cover was the Göteborg trial, which in part was an arm of the European trial, although the final publication included more. It included 20,000 men. These men were screened. They were younger men from 50 to 69, and at 14 years, this trial showed a highly significant reduction in mortality of 44%. Now, the problem with all of this is, of course, that there is a disadvantage. Can you take that out? A disadvantage in the time of diagnosis, because the point of diagnosis is moved forward by, here it was an average 4.5 years. This is the lead time, and this basically means that the patient has an additional 4.5 years of life where he would otherwise be without symptoms or treatment, and this is an asymptomatic phase where he really has a negative effect of this screening. The other issue is that we are picking up cancers with this screening, which are very early cancers where many of us believe that these are not really clinically significant cancers. This is an older study from the Rotterdam arm of the study, where at a time when every patient more or less had a radical prostatectomy, and it basically shows that the number of organ-confined cancers and non-palpable cancers is multifold higher in the screened arm than in the control arm. And the idea was at that time, or the calculation, that there is a 49% result of overdiagnosis and overtreatment. Now, if we look at the mortality. What we've also learned in the meantime is that many of these cancers which we're picking up, especially the Gleason score 6 cancers, are cancers with a very low mortality. We know today, this is data from the Sloan Kettering in the United States, in patients who had a radical prostatectomy, Gleason score cancers after 20 years had a cancer-specific mortality of 1.2%, and 30% died of other causes. And the message from that is basically that Gleason score 6 is not aggressive. Some people even think it may not be cancer. But anyhow, there really doesn't seem to be so much interest in picking up these cancers. So that there is an extra morbidity. Now we have changed this a bit, and especially in the Gothenburg arm, active surveillance has already been considered more actively, but they looked at their morbidity figures, and for each prevented prostate cancer death, just under 1 man became incontinent and 4 men suffered erectile dysfunction. Basically what these figures show is the facts are systematic screening reduces prostate cancer mortality, but at a considerable expense of overdiagnosis and overtreatment. And we have to improve this factor if we are to justify early diagnosis in this way. Now there are ways of doing this. We call it smart screening, which is not systematic screening as was done in these trials. The issues are, number one, screen only who potentially profits, and that boils down to starting earlier, stopping earlier, and having risk-adapted intervals. Second point is biopsy only with a good reason. I confirm that normal PSA, is it benign, is it enlarged prostate, look at additional biomarkers which may be available, magnetic resonance imaging, family history, and so on. And finally, to treat only cancers that need it, and that puts active surveillance for low-risk prostate cancer in a very prominent position. Let's go through these points in step. First, from the ERSPC study, which used a 4-year screening interval, when we look at patients who were screened again after 4 years and had a positive biopsies, there were clear risk factors that came out. One was age. The older you get, the higher your risk of prostate cancer. The other, and this was the most pronounced one, was a higher PSA. This was the decisive factor. In fact, a PSA over 1.5 was a critical, highly significant factor. Abnormal DRE was not so pronounced. A very important factor was prostate volume. This is a negative risk factor. The bigger the prostate, the lower the risk of a positive biopsy. And finally, one of the most important factors was a previous negative biopsy that really cut down the risk of another positive biopsy. Now, this was the ERSPC study. We had another study, the REDUCE trial, which was very similar like the PCPT trial, not a very clinical trial because patients that had a negative biopsy but a high PSA or a larger prostate routinely had 2 more biopsies at 2-year intervals. And looking at the risk factors for having a positive second biopsy, you see that the critical issues are, again, age, with higher age, more. These are quartile analyses. These are fourths of looking at the factors down here. It was age, it was PSA, there's a continuum, the higher, the more risk. It was family history, especially if there were multiple first-line relatives which had prostate cancer. This was highly significant. But please note, this is a negative factor, and the bigger the prostate volume was, the lower the risk. This is the biggest prostate, this is the lowest prostate, the smallest prostate. It was a reverse risk factor. Now, when we look at prostatic enlargement, we urologists all know that, have to clearly point out that as we get older, our prostates grow. These are population-based studies which clearly show that, for example, in the 7th decade of life, about 50% of all of our patients have an enlarged prostate, which is a negative risk factor for prostate cancer because they have usually benign disease, and many of these patients have lower urinary symptoms, but not all. So even if we're talking about asymptomatic patients, many of these patients will have an enlarged prostate, and this is suggestive of benign prostatic disease. A typical patient, if we see a patient like this who has a typical what we call benign prostatic obstruction and an elevated PSA of 4.5, 7-8 years ago I would have biopsied him. Today I don't think this is necessary anymore because he has clear risk factors of having benign prostatic disease, and I do not think a patient like this would need an immediate biopsy as a first step. The other factor is if we're screening patients, we have to screen patients that profit from it, and the patients that profit from that are patients that would otherwise, if they have cancer, die from it. That is, they need a life expectancy. There is no point in screening patients that are 75, 80, 85, and in fact, no study has ever shown a positive effect. But just looking at that negative PLCO study, if one takes patients only which were considered very healthy with no morbidity or with very low comorbidity, suddenly we have a significant mortality advantage for those patients that are screened. And we come down to numbers to treat of 5 in order to save 1 patient dying from prostate cancer. So clearly, patients have to be healthy enough and have to have an age where they live a longer period of time. Screening only is useful in patients with a life expectancy of at least 15 years. Now, this brings in another option, and this is mainly looking at screening intervals, is how about future risks of prostate cancer? We have some great data from Sweden, from a Malmö preventive project, which was a cardiovascular project in the 80s, where patients had blood drawn before the year of 50, and they were followed up, and we know if they had developed prostate cancer or not. And this is a quartile analysis of the PSA in this population. And if you look at the patients which were age 60, the median PSA was 1 in this population. And in fact, all the patients that develop prostate cancer, only a smaller segment of the population, even in this high-risk quartile, develop cancer. But metastatic cancer, or clinical cancer, 90% came from that highest quartile above 2. And in fact, if one goes on and looks at I just lose too much time with this. Patients that had a PSA under 1, the chance of having, I have to go back. Can I? Basically, if patients have a PSA smaller than 1 at the age of 60, they had a 0.2% risk of dying from prostate cancer. That would imply, if we screen these patients repeatedly, if a patient has a PSA somewhere above 2, he should probably be followed very closely. And if it is under 1, this does not have to be such close. It could be an interval of maybe 4 years. This study has recently been continued, and they looked at patients' PSA before the age of 50. And here the figures are even more convincing. The median PSA in this age group was 0.62. And if we take patients which were below 0.62, the chance of having prostate cancer, which was deadly, in the next 25 years was less than 5%. What this signalizes is someone who has a PSA around the age of 50, which is under 0.6, really doesn't have to be followed up so closely. It's useless. If he has another screening in maybe 8 years, this is what the authors suggested, that is probably enough. On the other side, if he has a PSA of over, let's say, 1, which is the highest quartile, he needs to be followed up more closely. What we're doing here is we're seeing basically the patients who need good surveillance versus just mild surveillance, and this is again PSA driven. Now the next issue is biopsy only a patient who really needs a biopsy. Up until about 5 years ago, we would routinely biopsy everyone who has a PSA under 4 or under 3, or lately even after below 2.5. Well, this has changed today. We today think that this has to be looked at much more precisely. We have prognosticators, like PSA3, but what I really like best is the prognosticators. Can you take that away? Prognosticators like, for example, this now new 4-calicrane panel, which is much better in predicting a biopsy outcome. You see that, for example, if we have just PSA age and DRE and use this as the area under the curve, we have 0.69, and if we use the calicranes, it goes up to 7.76. Most important apparently being the free to total, but overall it was the number of all 4 of them that made the big difference. And if we're looking at the ones we really want to find, high-grade cancer, this is much more pronounced. In the high-grade cancers, we have an area under the curve of 0.83, which is very, very good. These panels are not yet on the market. However, what they will give us in short period of time, they will help us identify a patient who has an elevated PSA or one of these markers, but by using them all together has a higher risk. And if, for example, we would consider a risk of 1/7 or less of the patients having a positive biopsy as an acceptable risk factor, the biopsy rate could be reduced by 50%. Now, finally, I'd like to say a word about risk calculators. In the last 10 years, we have been looking at risk factors all the time and have been very happy with it. The problem with risk calculators, and this includes basically every risk calculator that's out there, is that they only apply for the population they were trained on and developed on. And this is a typical example. The PCPT risk calculator is an excellent calculator. It was developed on the PCPT patient data. These were patients with a PSA under 3 that had an end of the study biopsy. And when we applied the same risk calculator to 10 different population databases, it varied from very helpful to completely useless. Basically, the message is that if you're using a risk calculator, and we very much recommend that, it has to be used on a population which is very similar to the population the risk calculator was developed on. Now, finally, a big message. The burden of screening comes from treating unnecessary cancers which do not need treatment. And here active surveillance is the big issue. And active surveillance is a hot issue. We still do not really know who should have active treatment, what stage, what grade, what PSA, is there a role for this in Gleason score 7 cancers. And we also know that over a longer period of time, a large number of these patients will ultimately have treatment after all, and it would be very attractive to define these populations in time. So we need a prognosticator of aggression. And here again, these clinical models are already quite good. This is a model very similar to the Steyerberg calculator. You see that if you use age, total PSA, the number of positive cores, the millimeters of cancer, Gleason score, and the clinical stage, the area under the curve for high-risk cancers becomes quite good. But by using a 4 kallikrein panel, this could even be improved to 0.84. And this is an important help which will really reduce the burden of screening. So to end up, what are our trends in the last 2 years? We have moved away from systematic screening, but I think, and I strongly think, that opportunistic screening based on individual cost-benefit ratios in informed patients is still a very important issue. Screening intervals and biopsy decisions have to be based on baseline PSA and individual risk factors, and the treatment of cancer which is detected has to be based on the aggressiveness of the detected cancer. PSA is still the key factor in this. And this sort of ends my presentation at this point, and I would now like to move over to your questions and to the questions and answers.